for this wonderful support to Diabetes India and supporting this talk also. What I'm going to talk in next 15 to 20 minutes, Imeglimin, it's a very important topic for which I just want to convey the message that how important it is in our clinical practice. So I have a conflict of interest here, but it's as I'm talking for this, but it's all presentation which I am going to do for next 15-20 minutes, lot of inputs for my side. Imeglimin, the milestone. If you just see in 2015, the phase 2 clinical trial. In 2016 to 17, it was almost in a phase 2 to phase 3 trial. And in 2018 onward, it was already available. And NDA submission for 2020, it was approved in Japan in 2021. And what is best news, it is approved in India in 2022. And we are congratulating here Zydus that they have brought this molecule to India and one of the very novel therapeutic agents for managing type 2 diabetes. And DCGI has approved this Imeglimin for users of type 2 diabetes. A quick recap of mechanism of action of Imeglimin. It is at mitochondrial pathway. It is partially inhibit complex 1, reduces reactive oxygen species, restores complex 3 function, it prevents MPTP opening, lessens release of pro-apoptotic proteins and increase ADP generation. So this may look slightly difficult, but in very shortly I can say it is working at a level where the insulin resistance or the beta cell dysfunction starts and other cellular metabolic pathways, and it is also working at an insulin sensitizing effect, which is enhancing the insulin action. And we know that insulin resistance both at the level of muscles and the liver. The liver, where it reduces excessive gluconeogenesis, which is one of the very challenging aspect of managing hyperglycemia in type 2 diabetes. And we also know that Indians are sarcopenic, we have our thin fat Indians, and we have a lot of insulin resistance, where it works at the level of muscle, where it increases insulin signaling and stimulates glucose uptake. It improves beta cell function and protection, which increases glucose dependent insulin secretion, prevents beta cell death and increase functional beta cell mass. So this is very important action which is at the level of pancreas, at the level of beta cell function, where it is apoptosis of beta cell is also prevented, and it increases glucose dependent insulin secretion, so there is no risk of increasing hypoglycemia too. Now, what the data? Because we are in a scientific meeting, we always wanted to, before starting any molecule to our patients or practice, we want to know what are the data for that. And the times, which is a 213 patient, then there is a times 2 with 714, and then times 3 with 215 patient. These are the phase 3 double-blind randomized controlled trial. Now these trials were where dose of Imeglimin used was 1000 milligram twice daily. The A1C reduction was 0.87. The A1C reduction in times 2 study as a first add-on was around with DPP-4, with pioglitazone, with metformin and SGLT2. It was around 0.88 to 0.9. And in times 3 study, when these patients were already on insulin, even it has shown the HbA1c reduction of 0.6. Now, this is very important from clinician perspective. Study has been done, which is a drag knife, where the patient was given first, it was newly detected diabetes. In these, they were already on one already existing drug, which means it's a first add-on therapy with Imeglimin, and still it had shown with the existing oral anti-diabetic agent, still a significant amount of A1C reduction. And then you see, these are the patients who are on insulin. Who will be the type 2 diabetic patient on insulin? It means a long duration of diabetes. It means this molecule working not even at the new onset of diabetes, but even with the longer duration of diabetes patients also. Now, what the data about the Indian patients? And we are again thanking here the Zydus for doing a largest Indian study for Imeglimin, that's India Times, where patients who were recently published, it was in Diabetes Therapy in journal in 2025. It is 8,000 plus real world data with 190 sites. It is 190 sites. It's an India Times study, a large scale study which we have done, a largest Indian study with 8,300 type 1 patients, type 2 diabetic patients, where 1000 milligram twice daily dose was there. Pan India with 191 with 3-month duration with baseline A1C of 7 to 9. This is what the baseline A1C of these patients. Summary of changes of these patients. The HbA1c reduction was 1.12. Here you can see the FPG reduction of 29.41 with post-meal glucose reduction was 62.41. Now we have the data from continuous glucose monitoring. That's the time when today when you are using any molecule, do we have data with continuous glucose monitoring? We wanted to know about the glycemic variability. You'll be surprised to know the patients who are put on imeglimin on a daily glycemic profile. It has completely came down. You can see the glycemic variability and time in range. Now we moved from A1C to time in range, and it has shown the time in range has improved from 67.9 to 79.5%. And that's very, very important with a continuous glucose monitoring in this particular times data. Now, why we are treating diabetes patients? We don't want them to develop a cardiovascular issue. That's very, very important. We want them to prevent cardiovascular problem in them. So we should have a CV safety data. And the evidence from cardiovascular safety data, absence of QTC prolongation. We have seen that some of anti-diabetic agents which prolong QTC, which can increase the risk of arrhythmia. This is absence of QT prolongation in through QT study of imeglimin with a first-in-class oral agent for type 2 diabetes. This is the dose which they had used against the placebo, and you can see here the doses which you higher. Why we had shown you the higher doses? Even with this high dose also, it had not shown any increase in imeglimin. And even it had shown with the moxifloxacin, one of the quinolones, which can further increase QT interval. Even in combination of that, there was no increase in QT interval. So this had shown, the study had demonstrated the therapeutic and even in supratherapeutic exposure of imeglimin did not induce a QT or QT corrected prolongation with a strong confidence as a evidence by this assay sensitivity. And that's very important for all of us to understand that how safe it is. Safety and efficacy, A1C I had already shown significant reduction with p-value of very significant from 8.2 to 7.5. One more important is SGPT, ALT. We are worried of person with diabetes, with a fatty liver disease. Now we know that it's a very, very important area, and with each and every diabetic patient we are worried of fatty liver disease. We have here fibro scan. Those doctors who wanted to get their even liver scan, they can get it. Again, thanks to Zydus for that. And it is the molecule which is SGPT reducing significantly from 30.9 to 22. So that's what it's showing, not only liver safety but rather it decreased SGPT. eGFR is stable, no decline in that. I am going to show you some renal data too. Stage B, where AST and ALT both decrease significantly, and stage C, no changes. It improves glycemic control, lower ALT in type 2 diabetes with heart failure, and it appears to be very, very safe. Now what about the data with renal? Because we have a lot of patients where we find that their eGFR started getting decreased, whether we can give you the decreased eGFR also. So that's the data which I wanted to show you. It's a long-term safety and efficacy of imeglimin in Japanese individuals with type 2 diabetes with chronic kidney disease. It's a 52-week post-marketing clinical study, and this is a twinkle data which had shown imeglimin may represent a valuable and novel treatment option in individuals with a CKD, and this population is also very high. We know in our country too, and a population with limited hypoglycemic treatment option. And this had shown it's a safety and efficacy with the patients who are even undergoing dialysis. It means in an end stage renal failure where the fasting plasma glucose significantly again reduced from 140 to 126. A1C reduction you can see here from 7.2 to 6.7, so that's a may not be non-significant from p-value point of view, but the absolute number is very important. You have a relatively controlled diabetic patient, but still you are achieving a further tighter glycemic control without getting hypoglycemia. That's very, very important. So you have a baseline A1C of 7.2 to coming down to 6.7 without causing any hypoglycemia, and that to a patient of CKD. The SGPT again decreased from 14.5 to 10.3. No lipid profile changes, and found to very safe, no side effects for hypoglycemia and GI symptoms. Imeglimin appears very safe and effective for glycemic control in patients who are on dialysis. If I compare with metformin, because that's always a comparison we wanted to use, and since years, almost 50 years plus, we are using metformin is the first choice. Even we don't have very sufficient data that why we are using only metformin, but because traditionally we started using it, and still after 75 years or with this, we are not able to change as a first line. But I just wanted to compare it with metformin and imeglimin. Imeglimin found to be having a islet beta cell protective with preserving beta cell mass. Now, why we are treating diabetes? Not just for the glycemic control. We have to treat disease itself. And this is the molecule which is having a mechanism of action by protecting beta cell and preserving beta cell mass. While metformin, we have data in vitro for beta cell protection, but we don't have any in vivo study to show that its effect on beta cell mass. So that's very important, that imeglimin in compared to metformin, to show that it does not have, metformin does not have vivo effect on beta cell mass while imeglimin have. If I compare for the intracellular mechanism, the imeglimin have increased NAD synthesis potentially by NAMPT, while there is no effect on NAD reported by metformin. Increased glucose responsive intracellular calcium, while there is no increase in calcium by metformin, and that's at a very cellular pathway, how it is different from metformin is different from imeglimin. Imeglimin has lower risk of lactic acidosis than metformin. And we know that metformin, particularly in patient with renal failure, with patient with end-stage liver disease, with patient with COPD or with the oxygen saturation low, it can lead to increased risk of lactic acidosis, while imeglimin is found to be safe and no increase in risk of that. Now, this is one more real-world data to assess safety, tolerability and effectiveness of imeglimin among people with type 2 diabetes who are intolerant to metformin. So these are the patients where we have taken who are intolerant to metformin, and this is a PRISM study from India demonstrating a very robust efficacy and high tolerability in large multi-center real-world cohort with a mean age of 53.1 years with a high prevalence of cardio comorbidity across India. The study provides clinicians with necessary confidence to prescribe imeglimin to their metformin intolerant patients. And we have around 10% of your patients who are started on metformin, maybe metformin intolerant, either because of their gastric upset, maybe because of diarrhea, and we are always in need of some alternative treatment for these patients. We also have imeglimin to be used when you can't use metformin, like in a patient with CKD. So some of these patients, the baseline here with HbA1c of 8.5 is decreased over a months and 6 months period with a significant p-value. A1c reduction was significant, and these were the patients who are metformin intolerant. And this paper we have published in JAPI. I was part of it, along with me Krishna Shashadri, Dr. Wagnu, who was supposed to give the talk for this, and last moment it is changed, and I am giving. So I am thanking Dr. Wagnu as well as to Jaidus for giving me this opportunity. And this has been in JAPI, which has been published. And the recommendation in this particular paper we have given that it can be administered as a monotherapy in treatment naive patient in type 2 diabetes. It could be considered as a monotherapy in patient who are intolerant to metformin. It can be considered in the patient who have postprandial hyperglycemia. It can be considered as an add-on therapy after metformin, sulfonylurea or DPP-4, which most of your patients will be there. Considered as an add-on therapy even after SGLT2 inhibitor 2. So either as a first line or as a first add-on, this is the molecule. It can be used even with a long-standing diabetes when you are not able to use any other molecule. Either they are metformin intolerant or having CKD. Imeglimin add-on can be considered for treating even elderly patient. That data is also shown. So the take-home message after this talk that imeglimin has shown to have very positive impact on skeletal muscle glucose uptake, hepatic glucose production, beta cell apoptosis, and important targets, particularly for Asian Indians, as they are having more insulin resistance and muscle mass is low. So that's very important message. It has demonstrated a very good efficacy with monotherapy and also with combination therapy, with maximum benefit seen when used concomitantly with DPP-4 inhibitor, which is very commonly prescribed in our country. It had shown better tolerance, less adverse reaction as compared to many other drugs, and I had shown you the data of hepatic safety, renal safety, and using imeglimin even in patients who have compromised renal and hepatic function. With this, I thank and thanks once again to all the people who are here. Thank you for listening me, and thanks to chairperson for giving me this wonderful opportunity. Thank you.